the topics for the witness seminars, we thought that it will be ideal to focus it on looking at the history of public health with relation to one particular area, and that is TB. And so what we tried to explore was this witness seminars being focused on one, trying to understand the history of public health and the way it has evolved in India, including how patient, participant, and community involvement has been approached. And that being from the perspectives of those who were involved in the design, those who studied it initially when the program was being developed, but also equally and perhaps more importantly, the perspectives of those who've been impacted by TB. So TB champions, TB survivors, persons who have lived with TB, and community-based organizations who are working in the TB space. So we are now extremely delighted that those two witness seminars, which we conducted late last year, have now been processed in terms of a report being available. We are also hopeful that we will release the videos of those two witness seminars in the near future. But today's event focuses specifically on the reports, and we are of course very thankful to the funding support which was provided by the TDR initiative as well. So today's event will hence focus on these two reports, which we will formally release today, and we will have some discussion around these various perspectives. Sunita and I and many other colleagues have been very interested in the field of community engagement and trying to explore this. We worked in the past with colleagues like Jim, who's also on this call, in trying to understand the various perspectives around community engagement. What does it truly mean? What kind of metrics should we be looking at? How do you evaluate? And how do you really make it meaningful? So I hope some of those will also come up today. And we are very thankful to all of our panelists and to all of you who have decided to spend the next 1 hour, 15 minutes with us, listening into the various perspectives that will be shared. Of course, none of this would be possible. Sunita, if you could go to the next slide, without all our witnesses who actively contributed to the discussions and their role in sharing their own perspectives on these two important topics, both on the historical trajectory as well as the role of communities and community engagement, and situating that within their own lived experiences with respect to the disease, either as people who have worked or researched in this area, who've done health system development, who've done programs, or who have themselves undergone TB and have survived and are now speaking about the richness and the importance of survivor perspectives. So once again, very thankful to our witnesses. As you will see on the slide, these were our witnesses for seminar 1, which looked at the historical trajectory, individuals who've been involved in TB research, TB program development, the documentation of TB as it has been historically sort of developing as a field in India, as well as individuals who have worked in the community on these perspectives. And we were, of course, very indebted to get their perspectives. And with the seminar 2, which specifically focused on the role and perspectives of TB survivors, TB champions, community-based organizations working in this space, as well as some activists who are working in the TB space as well. So thank you again to all our witnesses, and you will hear more around what they shared when the reports are released. I will now hand the microphone and the stage over to Sunita, who's the lead from FMES on this project and is also the co-principal investigator. Sunita, over to you.
Thank you, Anand. Thank you, Anand, for that sort of, good introduction and locating the witness seminar in the larger context. So I'm going to really take 2 minutes to talk briefly about FMES. I see many friends and colleagues here who would know FMES, but I also know that there are friends and colleagues from the grantees team under this WHO collaborative community engagement implementation grant, and they probably would not know. So let me begin with FMES and little introduction. So Forum for Medical Ethics Society is now in 30th year. So we are really commemorating our 30th year. It has 3 major platforms, and it is Indian Journal of Medical Ethics. Many of you would be familiar with it. This is again a 30-year-old kind of publication or the journal that we are running. The other 2 platforms are, we have started National Bioethics Conference platform in 2005, and every 2 years we organize conferences on relevant thematics. And the third platform is called the Health, Ethics and Law Institute for Training, Research and Advocacy. And it's a programmatic platform, very new. We are really in nascent phases at the moment. And this current grant is located at the Heal Institute in that sense. So broadly speaking, we really work in research, advocacy and training spaces, and really look at health as a much wider kind of conception, and also look at bioethics in a much wider context. About the grant, and Anand already had said about the grant, I just want to kind of, provide an opening pitch for this conversation. And as Anand said, that we've been working in community engagement. We are very delighted to have all the panelists, but particularly Jim Lavery, because me and Anand, we learned about community engagement with him at the University of Toronto, and we are very delighted to have him. He has extensive scholarship in community engagement. I just wanted to make 2 points here, and one is that there are a lot of advances in the technology, diagnostic, drug development that are taking place, which are important for improving the health and well-being of the global population. We are also working in the context of the SDGs, and several other programs such as TB also has global agenda called End TB kind of agenda, and they all kind of align with each other. So in all these are all very important elements, and some of you who are familiar with rations, who kind of, we have Anurag and Madhvi here, they're working on the role of nutrition in kind of, reducing the activation of tuberculosis in families. So important role that nutrition plays. So these are all very important facets of the public health intervention, as they have been in the biomedical research. I think one of the elements that we are talking today is the role of community and stakeholder engagement. And without that, I mean, there have been times when communities were kind of being referred to as important kind of stakeholders in the phases of last mile, when you want to take your health products or technologies or public health intervention, delivering them. But now over 10-15 years, the discourse has vastly changed. And the argument is, if you kind of involve stakeholders and communities right from the designing of the trials or the implementation designs of the public health intervention. And so they need to be really the equal partners and the players to really kind of, aim at better outcomes and better uptake of the public health intervention. And so we do have the backgrounders in terms of what we have witnessed in HIV/AIDS spaces, both in terms of biomedical research, but also rolling out public health intervention. And we all have witnessed that over kind of, soon after, I would say late 90s and onwards. But I think eventually, probably we have lost somewhere the way. And there is kind of very uneven uptake of the conception of the and the importance of the community and stakeholder engagement. And my third point here is we are looking at the TB program and their evolution in India, but also how it has informed the evolution globally, and what has been taken up by WHO over last 5-6 decades. I don't work in TB spaces, but when I started reading the material, I realized that many of the public health interventions and the design of those intervention were tried out in Indian context way back in 50s and early 60s. And then they were kind of, scaled up, and then WHO had taken it up for kind of, to be kind of employed or used in other contexts globally. So I think it is really important to underscore the significance of community and stakeholder engagement, along with many other factors, which I just said, the advances in technologies, drug development, and diagnostic. But if we want to have a better uptake, and if I can use the word buy-ins from different stakeholders, it's very important. And my last point is, we'll have to also go beyond mechanistic approaches to community engagement, and we would hear a little more about that from Jim Lavery in this conversation. With this, I'll invite Dr. Madhvi to talk and give the introduction of the CNS, which is one of the collaborators on this grant, and on the witness seminar that we have conducted. Madhavi, over to you, please. Thank you.
Thanks, Anant and Sunita. Hello, everyone. So, hello from Jharkhand. We are actually in Jharkhand for the trial which Sunita just mentioned, the rations trial. So, Center for Nutrition is a 4.5-year-old vertical within the Yenagoya University. It was started in October 2017 with the basic aim to promote advocacy, research, and public health nutrition, because nutrition is an important area for communicable as well as non-communicable diseases. And we have been collaborating very closely with the National TB Program, Ministry of Health and Family Welfare in various committees and made representations. And we also collaborate with National Institute of Nutrition, National Institute of Research in Tuberculosis, Chennai, and Lady Irwin College, New Delhi. And two important, apart from other things, two important contributions that I would like to mention from Center for Nutrition Studies is the framing of the guidance document for nutrition care and support of patients with tuberculosis in India, which is available in the Central TB Division website, and the NTB app, which is now incorporated within the larger Arogya Sathi app at the moment. So about the rations trial through which we started this collaboration with FMES, it's a cluster randomized trial in 4 districts of Jharkhand. We are looking at 28 blocks, and we have enrolled 2,800 patients and their family members. So almost we have 13,000 participants at the moment, and it's more than 2.5 years now. Will be ending in August. And here the hypothesis, so we have, there is no intervention arm as far as patients are concerned. We give dry food rations to patients in both the arms. And in the control arm, the families get dry rations. And the hypothesis being that if we give good nutrition to households, the incidence of new cases in households will reduce. So with that background, I'll not take much time because I'm very eager to listen to the participants. Over to you, Anant and Sunita.
We would like to hand over the floor to Anurag, please. Anurag, over to you, please.
Thank you very much, Sunita, Anant. I have been given this honor of moderating this release session. Before that, I'll just take a minute or two to just highlight, to make some points. So the witness seminars and the reports present a picture of the origins and evolution of the TB program in India, an account of the challenges both in the past and the present, and insights and perspectives from those who have engaged with the program, who have engaged with the affected people and communities, and who have been affected themselves. So there are there are very candid and valid comments on both medical and social issues affecting related to diagnosis, treatment of care of patients with TB in these witness seminar reports. But I just wish to make 3 points to paint and point to a larger picture and larger challenges. The first one is, while India made significant innovations in the diagnosis and treatment of TB, the Madras trial, and we had a sophisticated sociological understanding of TB, but our NTP, National Tuberculosis Program, was still operating within the strictly biomedical framework, which was the norm globally. And it was only recently in the last 5 years that these TB strategies incorporating patient as well as community perspectives. The second point is that the program as well as the general health services on which it is heavily dependent were low in political priority and suffered a lack of resources which affected its functioning. So the criticisms which about lack of access, quality and continuity of care still affects large group of patients who do not have tuberculosis. So while we are concerned and we should be about access to newer drugs for drug-resistant TB, For example, patients in asthma still have to struggle for inhaler therapies, or patients with diabetes still have to, have no assured access to insulin. So that is the kind of larger problem. But hopefully, 2 words have finally entered the lexicon of the TB program nationally and globally. And these are the words of patient-centered care and community engagement. So it's all for all of us to unlock the power latent in these concepts so that it becomes real for patients and communities rather than rhetoric. So the issues are larger issues are health for all, especially for marginalized communities, democratization of decision-making in public health programs, and access to quality, dignified, and rights-based healthcare. So I'll now, with these points, we'll start the session. I wish to invite Dr. Michael Mehut, Head of the Program Innovation and Management Unit at the WHO TDR in Geneva. Dr. Michael has been responsible for the initiative, the call for identification of good practices in engaging communities in research for implementation in health in LMICs, under which FEME has got this project. He will be providing an overview of this particular initiative and may help place these proceedings in the larger context of TDR's sustained work in implementation science, community stakeholder engagement, and ethics of implementation research. Dr. Michael has been trained both in medicine and management, and we are very fortunate that he accepted our invitation at short notice to attend this session. Dr. Michael, please.
Thank you very much, and it's a great honor to be here and listen to the results of the presentation of the results of your work. So thank you for inviting me. As it was mentioned by Anurag, we in TDR, we have quite a long history in researching community engagement into various areas, such as clinical research, community engagement in implementation research, and lately we are looking at community engagement into social innovation. This is another area that has the focus of TDR in the last few years, as we realize that if we want to get to the Sustainable Development Goals targets, it's not enough to have the push, the top-down push towards greater universal health coverage and towards better health for all. But it's important to have the pull element from the community. It's important to listen to them, to see what their concerns are, to listen to them, to see what their priorities are. And therefore, we are trying to gather now through this portfolio of 10 projects across 10 different countries. We are trying to gather examples of good practice in community engagement, both in research and in social innovation, including in ethics, so that we can then derive some conclusions and maybe some ideas to improve this, to scale it up what works. It's also important, as Anurag said before me, to hear what hasn't worked and to look at the various factors that maybe hampered the implementation of health interventions and that made the communities reluctant to engage in research. And we know that there were some well-known failures recently. So we need to hear the perspectives from the community side. In this sense, we are very happy to see that you have actually spoken to representatives from the community, that you did this grassroots work to ask them the questions and to hear their insights. Because without this, we cannot be sure that we really understand the concerns of the community to be able to improve our projects in the future. Of course, CDR has done work in, for example, if you remember, the onchocerciasis elimination program. We have tested community engagement strategies through community health workers and through local leaders. And this CDI, community CDI interventions model, which helped reach out to dozens of millions of people, which otherwise the health system couldn't reach. So we are always open to hear if there is an innovative approach that we can use, if there is anything we can learn from the researchers and scientists on one hand, from the professionals, international disease control programs, and in this case, especially from the community, because this is the part that largely goes unnoticed and unwritten in scientific journals. So I apologize for my colleague, Dr. Abraham Asefa, as this is a project that he loves, and he wanted to be here, but he's traveling, unfortunately, and he doesn't have any internet connectivity today. Again, thank you very much also for including in your research the marginalized communities and the vulnerable populations. These are our focus groups in TDR as we move forward towards the not leaving anyone behind approach. And this goes across our research, our capacity strengthening operations, and our community engagement. So I'm very eager now to hear more about these projects that you've been running. Thank you so much.
Thank you very much, Dr. Michael, for those remarks and their perspective. And it's very encouraging to see a WHO body, engaged with this particular focus area of community engagement. I now invite Dr. Manan Ganguly, who is working with Ekta Niketan TB Center in District Devgarh in Jharkhand in India. And for those for whom the word Jharkhand may be unfamiliar, it is the land of forest, literally, and the second poorest state in India with a very difficult geography and with a high proportion of indigenous communities. Dr. Ganguly has trained in medicine from the University of Calcutta and did a master's in radiation biology from London University. People living in remote areas and belonging to marginalized communities continue to face barriers in accessing care for their health problems, including tuberculosis. And Dr. Ganguly has been actually working in the remote areas of Jharkhand, running a TB center and training other groups interested to serve difficult to reach communities. Dr. Ganguly will provide his critical comments on the proceeding of Witness Seminar 1, which is tracing the historical trajectory of community engagement in TB-related public health interventions in India, and reflect on the significance of these proceedings in the context of his own lived experience as a healthcare service provider in remote areas of Jharkhand. Over to you, Dr. Manan, whose work is actually inspirational for a lot of us who are engaged in clinical medicine and public health in India. Dr. Manan, can you take over, please?
Am I audible?
Yes, Dr. Manan.
Okay. Thank you, Anurag, for inviting me to this important discussion. Thank you all. I'm indeed very honored. Must admit a bit overwhelmed, because I'm these days not used to taking part in such discussions. Yes, large part of my professional career has been dealing with tuberculosis. Various countries, various settings, but mostly in a small place, right in the middle of a tribal village in Jharkhand, for where I am actually, but because of poor connectivity, I've come to the nearest town, which is about 20 kilometers from the village. A quick comment at the start that the community in question that the organizer of this seminar has rightly identified is the disadvantaged rural and indigenous communities across the country. So my focus or my work been around those people. Having worked in TB in Jharkhand in a tribal community for over 40 years this now, from pre 3 dots, 2 dots, to community dots, if you like. So I have indeed some insight, but I hope you will agree with me that addressing tuberculosis, particularly in a vast country like India, is very challenging. There are various aspects we need to address. In this context, that it will take a long time to address properly, particularly to reach out to the communities we are talking about. But so when we are talking about eliminating disease, which is far, far away, let alone control the disease. So that's what I feel important, even though late, but we are always late in tuberculosis. But we still, it's a good start, and thank you, the organizers of this seminar. It's a so important issue. Now, while I was going through the report, I just picked up some issues that have been raised or discussed. But so let me go through that very quickly without with no order in the document, in the seminar report. And that these are what I see. What is community in the context of TB intervention? It seems that there are debates, there are discussions, but we need to identify. And as I said, the community, the center of the discussion for this seminar is the key issue, and that we need to focus on. We're not then reaching out communities in TB intervention, and there are different perspectives that have been discussed. ASHA, TB champions, the top, stigma, and so forth. So that's another area being discussed. Engaging communities with TB programs or TB program engage with communities. That's something it's discussing possibly in the future. And the big the key question that some of you, Anurag, certainly very involved, is TB is a disease of poverty. But some of us, our public health specialists, we are a bit hesitant to say that, or we say differently. Yes, TB is a disease of poverty. Of course, TB is a medical condition, and the bacteria keeps in weak lungs, cripple the person, cripple the family. But the people we are talking about, people or the communities that this seminar has centered, they do not have good nutrition. That's what I understand, Anurag Board, that BMI is sometimes 14. Yes, and what we get here, yes, even 13. Some are almost 5. And then the question was that, is it patient-centered intervention, or is it people-centric intervention that we reflect upon? And then the discussion was the national tuberculosis intervention, strategies intervention, missed out perspective. These are part of this important document. And I repeat the same question: is it TB control or is it TB elimination? And then then also this report, this discussion touched upon public services versus privatization or a mix. I really remember early days we used to call PPM with something like private public mix. I will not, if I have time, I'll discuss, and that's, I think, a wrong approach of addressing TB in the communities I'm talking about. There are many. Then the question is, what is a holistic community-based tuberculosis intervention? Now, there are few issues that has not been adequately addressed in that discussion that I think the organizer will be exploring in the future, and that's like prevalence and intervention.
मैं कैंटीन से पानी भर के आ रही हूँ.
Extrapulmonary tuberculosis, and that's something worth addressing, looking into, and how do we engage communities in addressing that as well. And then, of course, TB among migrants, TB among women, and these are neglected areas, and this needs highlighting because these are the places where the communities we are talking about and these communities are somehow not really given adequate focus. Now, in terms of TB is a disease of poverty, or if we like to say that, there is a need to integrate medical dimension and social dimension, which is, we cannot, addressing poverty, we cannot address tuberculosis. And the poverty, if we look at it, then there is another aspect, it's question of dignity, question of access, question of power, and that these are all related. And these also then access related to attitude and alienation. So these are all linked with poverty. And that's, I think, something we need to look into it. But it's in the document, and it's rightly so, it's been also highlighted that TB intervention in three levels. One is surface. That's how it's been presented. Surface level, which is the bacteria germ theory. And then it is the intermediate, that is more distal causes, such as, undernutrition, purchasing power, and so forth. These are all, of course, related. And then the last one is the more underlying, deeper issue, and that is the development and welfare approach, who we are developing, and so forth. I think the national strategies, strategic plans, program implementation, and missed out perspective, these been discussed in that seminar, and I think key issues where there's been indeed some developments in the TB intervention in terms of how do you put it, ASHA and TB champion and fund disbursement and so forth. On the other hand, the question being raised that out-of-pocket expenditures of the communities or the people we are talking about, has it reduced? I remember early days, WHO strategy was to address zero catastrophic cost. The patient we have in our center, which is a small mud house, people coming various far away, and we document various aspects, including the cost, total cost, and that goes minimum 5,000 rupees to 20. I think this morning one came, I think, about unnecessary cost, and that prevails. So it's a question that we need to address again, that are we improving our intervention in communities? And the caution raised by various witnesses that there is a danger of very vertical medical aspects, medical thinking. That means drugs and genomic diagnostics and so forth, all equally important, but without reaching out people, without reaching out indigenous communities, communities in mining areas, communities among migrants, it will never be successful. So just medicine will not work. We need medicine, but it will not work. What is community in the context of TB intervention and reaching out communities? That was one of the discussion in that report. But it seemed to me that we are missing, we are lacking information, lacking understanding. How do we reach out? Because I think it's because the lack of practices, both governmental and non-governmental, in TB intervention in communities we are talking about. And that's why, where are the challenges? How do we reach it? Was it's something a bit weak part in this. So in this seminar discussion, but I think we have opportunities to look into further words. How do we reach people? What does it mean about reaching out? It seemed that there was a different ideas, but lacking practical information, if you like. Then the question came about, I'll be very quick, question about patient-centric or people-centric. And that's another area I also felt that I think we have to pin down what TB intervention in communities we are talking about. Without treating patient, we cannot reduce the number of TB patients. And so, but I guess a number of witnesses raised about it, highlighted. It will be not patient-centric, but people-centric. But I think it is from when it has been pointed out that it is not patient-centric, my understanding and guess is that the witnesses, they were meaning not medical-centric, I guess. But in a community, we are talking about an appropriate, holistic, community-based TV intervention. We'll have to have patient-centric intervention. But I think there was only patient-centric and people-centric. Patient-centric is intervention to me, and people-centric is more an approach or strategy, if you like. So I think there is no big difference between these two.
Dr. Manan, sorry for interrupting you, but can we have closing remarks by you? Because of the time.
Sorry. And then just to finish that point, that I think we must be away from center-centric. We are just not setting up a center, but we need to go to the people. And lastly is because of our lack of intervention in remote communities, lack of information, lack of practices, I think we are missing out that how do we reach? I think we have to, we're talking about community, but my opinion, it is to be patient and their families, and we have to reach there, and then and only then we can build up trust, if you like, reaching out, if you like, and that's how we've been trying, but we are still learning how best we can do. This is where I stop now, but I have highlighted a few areas that are missing, of which I think the psychosocial determinants of TB, or that's something lacking research, lacking. So in our center, we did try, but unfortunately, the medical research community, they don't understand the value of it. So I stop here now, and thank you.
Thank you very much, Dr. Manan, for being on this session and traveling 30 kilometers just to ensure better connectivity. We, of course, had the challenge of still the bandwidth. Thank you very much for those remarks on the Witness Seminar 1. And I think all the points that you raised about some of the gaps are valid ones, particularly with regard to catastrophic costs. I can just say that most of the costs are incurred before the diagnosis of TB is made, and most of the costs are an indirect cost of lost wages rather than sometimes direct cost in the program. Now I invite Dr. Jim Lavery, the Conrad Hilton Chair in Global Health Ethics at the Emory University Center for Ethics in Atlanta. Dr. Lavery has been one of the prominent voices in the area of practice and scholarship related to community and stakeholder engagement in biomedical and implementation research. He has worked in diverse settings and engaged deeply with a large number of research initiatives in global health. Dr. Lavery appreciates community stakeholder engagement as a possible game changer in global health, but also as a critique of mechanistic approaches to CSE and appreciates its limits. We invite him to locate the proceedings report of Witness Seminar 2, titled Community Engagement and Patient-Centered Care in TB-related public health interventions in India. Within the largest context of global health and and national programs which are responding to health conditions such as TB, HIV, etc. So, Dr. Lavery, we're very pleased to have you, and thank you for making the time.
Well, thank you, Dr. Bhargava, for that very kind introduction. And thank you also to Drs. Mihud and Dr. Ganguly for very insightful comments, and hopefully I can build on them here. I'd also like to thank you and congratulate you, Sunita and Anant in particular. You continue to make us very, very proud at the University of Toronto, and you're sorely missed by all of your friends and colleagues in Toronto, and also those of us who are no longer in Toronto here in Atlanta. And just like to thank and congratulate all the organizers and all the witnesses who I think are just amazing and very inspiring. So I'm really, really honored to be with you today to share just a few brief thoughts and observations about Witness Seminar Report number 2. And I'm going to share four thoughts. The first thought is that the Witness reports as a concept, I think is just it's a terrific concept. So this notion of testimony that this concept draws on, this idea of bearing witness, I think is very powerful. And this idea about gathering perspectives and gathering unique perspectives, I think, and presenting these unique insights, and especially insights about kind of less obvious issues. So for example, just one of many, many examples, the profound implications of hearing loss that were reported by one of the witnesses. These are often things that get missed. And I think the reports illuminate the experiences of living with TB that just can't be brought to light in any other way. So in that sense, and again, this is something I think that's not appreciated enough in the discussion about community and stakeholder engagement, but in that sense, they really have unique evidentiary value, and it tends to not be the way that we think about it. But I think we need to really think more about the nature of the evidence that these kinds of insights can provide us with. And really importantly then, following from that notion, they offer unique learning opportunities. And our work more recently has really turned to the focus on organizational learning and systems learning as the way that you derive value from stakeholder engagement. So this seems very much in line with that way of thinking. And in this case, you know, the learning is that the reports allow us to kind of improve our broad understanding of TB and its implications. But also, I think the reports humanize these issues in an incredibly important way. And perhaps, you know, they can improve our compassion, so they can kind of help to guide action, not just in an empathetic way, but also to show us areas where that empathy can be put to work in compassion. And if you look at some of the WHO's focus on quality in health systems, compassion is one of the 3 main anchors. So this seems to fit very, very nicely for me. And again, I think this goes right to the heart of the role and the value of community and stakeholder engagement. So the second point that I think follows from this is that the reports provide important insights about the design and performance of health systems. So, you know, reading the witness stories, I felt like someone in one of those TV ads, it was like wearing a virtual reality headset and visiting the health system. You know, the story, for example, about the young mother from a rural district having to navigate Mumbai with no knowledge of the system, very limited resources, and importantly, not even any knowledge of the kind of network of social supports that the people participating in this meeting have actually developed. And so I got a sense of these witness stories kind of like a system design inspection, you know, people looking at the system and making observations and sharing them. And I found that very powerful. And these insights that were experienced by the witnesses, they also reveal aspects of the system, I think, that represent real opportunities for problem solving and quality improvement. that could be enormously beneficial for health system designers, if they're willing to pay attention to and privilege the insights and the experiences of stakeholders that are revealed through these kind of novel strategies. And again, this goes back to my earlier point about the importance of thinking about stakeholder engagement and understanding it as a unique opportunity for learning. So there's a mindset that has to be prepared for that. But it seems to me that this could be, a major strategy for operationalizing the idea of patient-centered care, or as Dr. Ganguly just said, for person-centered or people-centered care. And again, I think it's really important to keep pushing this idea that these reports offer a different way of thinking about evidence. And that's something, I won't say any more about it, but it seems to me that this is part of how we can break through some of these impasses that we've experienced in the past, which is thinking differently about the nature of the evidence that's being generated. The third point, and Sunita and Anand, you were part of these discussions leading up to some of the writing about this idea, but we've written about community engagement as a kind of human infrastructure. And it seems to me that the witness reports reflect a sort of human infrastructure of care for people living with TB. So the engagement activities themselves, they're really aimed at reaching people in need of care and support. They're not gratuitous, they're really purposeful engagements. And the relationships that are established through these engagements really seem to be a kind of living interface or a potential interface with the health system. Certainly lots of observations about the health system. But I think this thinking about engagement in this way, and then the ways that I think is so nicely reflected in the reports, I think really can help us think better about how to bring the insights from communities into interaction with the health system in ways that really can improve their performance by identifying challenges and focusing on how those challenges can be solved. I was really struck by the concept of Saksham, and apologies if I'm not pronouncing that correctly, but this idea about making capable. And so, it seems to me that part of the focus was about helping patients and families be more capable of getting the appropriate care or working through debilitating experiences of stigma, marginalization, through advocacy and problem solving and advice and navigation and counseling and rights-based and legal approaches that are reflected so nicely in the report. But it seems to me that idea of Saksham, or making capable, is also about how we make the health system more capable of appreciating the implications of what one witness called information asymmetry, but also the many power asymmetries between healthcare providers, the system, and patients that are very, very clear through the reports. And critically, the reports, I think, make it very clear that the goal isn't simply to get healthcare providers and health systems to be nicer to people. I mean, I think this is still, some people still think this way about community engagement, but rather to improve their performance. And I think the example from one witness about improving guidance for the dosing of isoniazid, I thought was just an excellent example of that. A relatively straightforward insight, but it required some systems processing and learning in order to make the necessary changes. So the kinds of engagement that are reflected in these reports, I think we should view them as public health interventions, not just as community activities, which I think are often discounted, compared to more technical aspects of public health programming. And the final point on this third point about human infrastructure is we really do need, I think, to reconceptualize the relationships between patients and families and the health system in order to be able to drive this change. And again, back to this point that Dr. Ganguly made so nicely about people-centric approaches. One witness mentioned that some TB treatment guidelines don't even mention patients at all. And so I think, again, stakeholder engagement, community engagement have to be viewed as vehicles for learning that's required on both sides to make this possible. But more importantly, I think on the side of those in positions of power and authority, they have to be willing to learn. They must be willing to see patients and their families as fully realized human beings and partners, and reimagine their responsibilities and accountabilities to them. And I think, again, these reports offer a unique resource and a novel strategy to guide that reconceptualization. And my final point is just a couple of very quick observations about the relationship to implementation science. And I'll stop here because I'm just conscious of time. But I think in general, we still tend to think very narrowly about implementation science. It's mostly still about methods and trial design. But implementation science also has recognized ideas like knowledge co-production, the importance of context, various types of adaptive practices, and the importance of collaborative partnerships. But in my view, implementation science hasn't yet come to terms with the implications of the kinds of insights reflected in these reports and their unique evidentiary value for guiding program and policy design and implementation and tailoring as we kind of introduce these programs and approaches into communities. So I was very pleased to see Dr. Mehud involved in this meeting today. Very much appreciated your comments, Dr. Mehud. And I think that the kind of leadership that you and TDR are providing on this is incredibly important. And I think that what you have before you in these reports is some really terrific ideas about how this whole area can be developed and improved. So thank you again for the opportunity to share a few thoughts with you today. And I hope the reports have a really significant impact on the experiences of people living with TB in India and beyond. Thank you.
Thank you very much, Dr. Lavery, for those insightful comments and drawing on your own experience. Thank you very much. Now I invite Dr. Santosh Kumar Giri, Director of Kolkata RISTA. Dr. Giri is a trained clinician, an advocate for patients' rights, and has been working on the ground with various marginalized communities, especially the community of trans persons. She has been involved with diverse movements, including the Right to Food, Stop Gender-Based Violence, and 1 Billion Rising, and is on the steering committee of UHC 2030 as a community-based organization representative. She's a focal person for the Eastern Indian region for Touched by TB. We invite her to share her views about the relevance of these proceedings to the issues and concerns of the marginalized communities she closely works with. Dr. Santosh Kumar Giri.
Thank you very much for inviting me and to giving me this such good platform where, where we can, as a marginalized community, because I am from a marginalized community. I'm a trans person as well as I'm a TB survivor. So I know the real meaning of discrimination and violence and stigma amongst TB patients and all. Starting just 1 minute, I want to take that Kolkata RISTA is a translate community-based organization working in the 4 states of India, Bihar, Jharkhand, UP, and West Bengal. And we are working with the government as well as with the other agencies in India. And we are having our own targeted intervention programs, Global Fund supported programs, and other WSF programs in Calcutta and others in other states too. So the thing is that I just would like to start with the TB that I heard our friends, and which is a real, that report is really helping us to reach the unreached population. Like we are mentioning the marginalized community, that's very important. But I think it's supposed to be more clear about that who the marginalized communities are. They from the Dalit community or from any caste community, religions community, or from the gender or sexual minority community, which is very important. And I heard that Michael said about the USC, I know when as a steering committee of USC and CSCM 2030 that our main agenda is to leave no one behind. So the same thing which I'm repeating here, that we have to see how we can reach the unreached population and the last mile, and to bring the leave no one behind in a real meaning. It's not in that paper and page. It's supposed to be in the ground level, as well as to be in the field and in the community mind also. Because we did a research at the last year at Jharkhand with the transgender community, mainly on TB survivors and those who are more vulnerable towards TB, where it is clearly found, it is clearly showing that the community is not having such clear ideas about the TB, as well as the community is having the ideas about HIV, and which is something threatening. The government, like our government, is like, we are very pleased to that announcement of our Prime Minister that she said that we are going to end TB by 2025. But it is also important that we have to see that how we can, what will be the strategy, because we have to free our India by 2025 from TB. Then we have to see how we can be. And that is my first things to be bring it out to you people, as well as to Michael and others people and the researchers, those who are done that, what will be the next step to do ahead. So in the research, it is clearly mentioned the community is not having the ideas, not having the ideas about TB is what TB is. And the communities and the government is merging the TB and HIV program together, which is also one threatening that we need a single door access for the TB survivors, mainly for the marginalized community. Because it is something like when we as a transgender community or the sexual marginalized community is affected from HIV, and again from the TB, double, triple stigma is there. So we have to, I think we have to see how we can bring that single access over here. And again, I'm saying that which is also giving the strengthening to our USC for all and all. And as I know that there is very late, very small time is to talk. So I just want to make that we are going to completing 20 years of our journey in 2023. And I already spoke with Sunita that, Sunita, this is a platform which we can be able to bring the people, those who are from the real marginalized community, irrespective of any gender, sex, sexuality, and those who are more vulnerable towards TB. And can we be able to do a health conclave or a health conference, national health conference in India, in West Bengal? And because many times we can see that everything is happening in Delhi and all, then we can be able to bring it in West Bengal, and where the people from the marginalized community can speak and can create, can see what else we can be able to do as organization, as WHO, as UNDP, as government, as a civil society organizations and individuals. Because this is the time when we have to bring together, but together to make strengthening to our TB program, national TB program, and which is also this. I want to mention that we have to see that because that research is also mentioned that when we reach to the healthcare providers, the healthcare providers is also not having a clear ideas, because they have I have that email and all that they refuse to take 20 samples of the sputums of the trans people in West Bengal, that the transgenders people won't be able to check for TB, and it was a very big crisis over there. So we advocate them. We ask the Central TB Division to put their views and all, and Central TB Division is supported a lot for do that. So thanks to Dr. Raghuram and all others who did help supported us. So and the last, which I just want to mention that 1 minute, I just want to mention that how we can be able to because that research is I can't read that whole reports, but that report is now something as a platform, and we can see that how we can do some specific research on the specific community as a transgenders community. And I'm sorry, but friends, this is very true that we peoples as a transgenders people are stigmatized in every and each places. So we can see that if we really want to see or fulfill our SDGs agendas, our USA agendas, we can see how we can be able to do that. And I'm really apologize, I know, because this is a community voice, this is not my voice. So as a community representative, I am also requesting TDR and other and UN agencies and all to see how we can. We are welcome everybody to see, and we are ready for any such kind of discussion and any kind of meeting towards it. So as of now, this much. I have seen some of the hands are there, but we are not. I think it's very important to, if we can take some questions. Thank you very much, Sunita, and thank you very much, Michael and others who have given their inputs and views. Thank you.
I have one question.
Can we take questions at the end? We'll just we have just one more speaker. I request people to put the questions in the chat box, but we can also take individual questions. Thank you very much, Dr. Santosh, for making those comments. And I think what you spoke for the community that you're working with, the trans persons and other marginalized communities, is reaching out to a very wide cross section. In this program, we have academics, we have clinicians, we have public health professionals. So I think the points that you made and the suggestions that you made will be taken note of, I'm sure. In the end, we have Dr. Asha Frederick, who is Additional Director of Medical and Rural Health Services from the state of Tamil Nadu. And Tamil Nadu has a reputation of leading India in public health indicators and in programs. In fact, Tamil Nadu was the place where we launched the famous Madras studies. Dr. Frederick has training in medicine and public health with formal training also in TB and chest diseases. Before we announce the release of these reports and open the floor for discussion, we invite Dr. Frederick, who is both a clinician and a health administrator, to locate the proceedings in the two reports in her own work as part of the public health system and TB program in Tamil Nadu, particularly her own experience working as state TB officer in the National TB Elimination Program in Tamil Nadu. Thank you very much for accepting our invitation, Dr. Asha, and the floor is yours.
Thank you, Dr. Ara. So I have a good evening from India to all the participants. So first of all, I would like to congratulate on this e-release to Forum for Medical Ethics Society. So having heard all of you and having gone through some of those the reports that were shared, as a state TB officer and an implementation person in the state of Tamil Nadu, I would like to once again thank for this release of this reports. So as an implementer, it gives me a lot of insights into where I can, how and where I can shape some of the implementations of this National TB Elimination Program, the services that are being offered to the patients from the side of the government. So as said, yes, Tamil Nadu has got a very good vision about how we engage with the community. And there were many such, we had development partners who started during the COVID lockdown. We identified some of the TB survivors and we started training them to be TB champions. We trained them to offer social, psychosocial support in the community. And we also could see involvement of TB leaders, women TB leaders in one of the REACH projects. So we were very happy in how it came out. And taking some of the cues from the witness reports, I would really say, because the community engagement aspect is very, very important in the sense where most of the researches are happening from the NIRT, which is, as traditionally, a lot of research, traditionally the Madras study, not just Madras study, we also have other studies that are coming from the National Institute of Research in TB. And our own state initiative during the COVID lockdown was to look at the various deaths that are happening, why there's an increase in deaths in TB. So when we did the exercise of verbal autopsy, we could analyze, and when we engaged on a one-to-one with the relatives of the patients who had passed away due to TB, we could find that most of the TB deaths did happen in the house. 68%, almost to the tune of 60-70% happened. They did not even seek medical aid. So most of them died in the house. So now this really put us in. We analyze these verbal autopsy. Then we have come up with something called triaging at the community level during the time of diagnosis, severely ill TB patients. So we would want to triage at the field level, and immediately once we find the patient is severely ill at the time of diagnosis, we wanted to provide them medical support by admitting them in the hospital. So slightly we are moving away from the domiciliary treatment to an inpatient care, enhancing the quality of care for the TB patients during the time of diagnosis. Also, we have now planned to provide them nutritional support. Already we are giving nutrition support, and here in Tamil Nadu, the public distribution system, we already have free of cost nutrition support to almost most of, even not just below poverty, but even above poverty line. But and over and above, we are planning to support them till their BMI improves. So we do have some cutoff. So right now, Tamil Nadu is also looking at triaging the severely ill patients and bringing down the mortality, because our aim is only towards the SDGs. This the important thing is to bring down the mortality rate, and of course our catastrophic cost. So this is again are one of the important goals for the TB program, elimination program in Tamil Nadu. And once again, I just want to say that the insights that are offered from this witness report will be of very use to managers like me, and would also start such more witness reports within my state, so that I would like to engage some of our district TB offices to use this report once it's released after today. So thank you for this opportunity. Thank you, everyone.
Thank you very much, Dr. Asha, for your comments, and it's very encouraging to learn of your initiatives in more comprehensive care of TB patients. That experience of most of the people dying at home is, even in normal times, shared by many groups across India. And even in our trial, we have witnessed this thing even in non-COVID times. So your initiative to give clinical evaluation to TB patients and then refer them appropriately is very welcome. And we have our own experience in Jharkhand to this effect. I will now, we'll just have the formal release electronically of the reports. I'm aware that we have gone over time, and there are a lot of our colleagues from all across India and even abroad who are here on this in the seminar. And it'll be not doing justice if we don't have questions. So this is the formal e-release of the witness seminar reports, and I think there's a slides on acknowledgements as well, but we now will open the floor for discussions. So people can pose their questions in the chat box, or they can raise their hands. And I think we can go over time to really do justice to all those colleagues who have attended this seminar. Hina Chatterjee, you can go ahead, please.
Yes, sir. I have one question, but I talk to Bengali. Please translate, Dr. Giri, madam. Dr. Santosh Kumar Giri.
Okay, I'll do.
Okay. বলছি যে তুমি ট্রান্সলেট করে দিও, হ্যাঁ? হ্যালো,
প্লিজ আমি করে দেব।
হ্যাঁ, বলছি যে আমি অনেকক্ষণ ধরে প্রথম থেকেই শুনছি, তো এখানে ইউএসসি বা ইউনিভার্সাল হেলথ কভারেজ নিয়ে অনেক কথাই হচ্ছিল, আলোচনা হচ্ছিল, বাট আমি নিজে একজন ট্রান্সজেন্ডার পার্সন, তো অ্যাজ এ ট্রান্সজেন্ডার কমিউনিটির হয়ে আমি কথা বলছি যে সেখানে এই ইউএসসির জায়গাটা আমাদের জন্য কোথায় আছে, ওইটা আমি একটু জানতে চাইছি।
Okay, Hina, I have a question that we all talk about the USC and all. Then where is the space of USC and in universal health coverage for transgender people?
Anybody who would respond? Dr. Michael or?
Sure, I can say a couple of words from the perspective of TDR. As I said, the focus of TDR is on vulnerable populations, marginalized populations, and leaving no one behind. And for this, we are looking to learn from the communities, from this research that you have been doing, and congratulations for releasing the 2 reports, to see how to best ensure that they are captured. You know, the classic approach is the top-down thing. Somebody has an idea, and then they say, okay, let's engage them this way, or let's engage them that way. And then you have rejection, and you have mistrust, and you can encounter even, and your program can fail. Our approach is different. We are trying to see how communities want to be engaged, how their priorities need to be addressed, and then we will design our approach around that. And somebody mentioned before this multi-sectoral transdisciplinary approach, meaning that we have to look at the intersection of the various fields, like and the various dimensions that define the social determinants of health. It's a very little use to address one of them and leave the other ones unaddressed. So from that perspective, we are learning from you, and thank you for these reports.
If there's nobody else responding, I can just respond quickly to what Hina's comments were, but it'll need translation for that. But basically, whenever we are talking of a public health program as part of any plan, numerous groups actually are not on the map. And I think the transgender community is one such group, which Dr. Santosh Giri said that courtesy, some people in the Central TB division now are getting facilitation of access, but it remains an excluded group. In India, we have the issue of, healthcare access for the migrant population. Again, they are not specifically on, the program because they are, living across states and cannot access services. So that's a huge group in India, which still needs to be have a special focus. And so it is with, whether it's the homeless people or, sexual minorities and etc. So, but it will be good to really specifically mention these communities. We have a huge problem, Dr. Manan Ganguly is working on occupational risk factors for TB in India. A lot of people develop TB due to silica exposure or due to effect of coal mine dust. So those are again still not getting the attention that they would. But this process, if it rolls on, it can just help recognizing these population groups whose needs are not being met at the moment. Thank you, Hina, for that.
हाँ है ना, इन्होंने जो कहा है माइकल ने, और ये सॉरी बहुत टाइम कम है, मैं बहुत कम अक्षर में बोल दूं कि बहुत जरूरी है। उन्होंने वो भी कहा है कि आपकी क्वेश्चंस को वेल टेकन किया गया है और वो उस पे काम करते हैं, वो इंटरसेक्शनलिटी के बारे में बात करते हैं लोग, वो लोग TDR उसको देखता है और फ्यूचर में भी वो उसके साथ भी काम कर सकते हैं। जैसे कि सर ने भी कहा है कि माइग्रेंट लेबर्स के बारे में हम लोग नहीं बात करते हैं बहुत जगह, तो वहां पे भी वो तुम्हारी बातों को भी वो एक मत होकर बात किए हैं। और ये जरूरी है कि किस तरह से हम मार्जिनलाइज कम्युनिटी को रीच कर एक साथ मिलके इसका एक बनना जरूरी है। क्योंकि आप सभी जानते हो कि एक इनफॉर्मल यूनियन कॉन्फ्रेंस में एक इनफॉर्मल टीवी का ट्रांसजेंडर नेटवर्क बना हुआ है, लेकिन रिसोर्स नहीं होने के कारण हम इसको चला नहीं पा रहे हैं। सो थैंक यू हैना फॉर दिस। थैंक यू।
थैंक यू मैम।
So Anurag, I just wanted to mention a question from Veena Shatrugna, and the question is, what is the future of community engagements with the coming of telemedicine? So if any panelists want to take it up, please.
Sunita, could you just repeat the question again?
Yeah, so the question is, what is the future of community engagement in the age of telemedicine? Am I audible?
Yeah. So I actually have to jump off in a few minutes. So maybe I'll just take a stab at this. You know, I think I actually see the question in two parts. One is, what's the future of community engagement? And then how does community engagement apply in the context of virtual care, which is, you know, an enormous issue around the world. COVID has really accelerated that. I tried to give you some hints in my comments about what I see as kind of one of the major areas, and we have some work coming out on this in the next few months. And it really is trying to understand these forms of engagement as unique opportunities for learning. And I think that sounds so straightforward, and it sounds as if that should be obvious, but we haven't organized our thinking about evidence, and we haven't organized our thinking about the design of programs in ways that really facilitate that kind of learning. In a lot of the work that we've done over the last few years in neglected tropical diseases, what we found is that in program implementation, everyone in a program is learning, but there's actually no conscious capacity within the organization to take in those insights and process them in ways that result in meaningful learning. So I think that I see that as if we can solve some of those design problems, I think the kinds of insights that are reflected in these reports could have enormous value for health system and health system improvement. On the virtual care side, I think one of the core ideas in community engagement and stakeholder engagement, and Anant and Sunita, we have discussed this for many years and written about this, is that they're fundamentally relational approaches. The kinds of insights that you get, again, that are reflected in the report, they're not the kind of things that you can get in a survey that are framed from the perspective of the person asking the question. They really require some form of relationship. You don't have to be married, but you have to be in some form of relationship with someone in order for them to feel that space where they can share the kinds of deep insights that you have, and particularly the ones that are non-obvious. It's very easy to get obvious insights. The ones that really matter are the ones that are less obvious and harder to get. So the question then about virtual care, I think, is how do you structure virtual care in a way that leaves open the possibility of some level of relationship where those kinds of insights can still happen, so that it's not so highly structured at the delivery side that people don't have space and don't feel that comfort. And again, I think largely these are issues of design. So I think it's a really terrific question. And I think if we can crack that one and figure out how to get a decent approximation of the kind of relationships that permit those insights, then I think that it can fit perfectly within a conception of stakeholder engagement.
Thank you, Dr. Lavery, for responding to that query by Veena Shatrugna. I'm seeing just the participant list, and I just wanted to point out that we have some colleagues who are very senior in the TB space. Dr. Sunil Khaparde was the previous Deputy Director General of TB in India and presently associated with HIV control. Dr. M.S. Jawahar was a trialist at the National Institute of Research in TB, who has also joined in. And of course, there are academics from social sciences also, and people working in very difficult to reach communities, for difficult to reach communities in India, like Dr. Aquinas, who runs a primary care program in Odisha. So I'm really fortunate that these people have joined, and we are running short of time, but we could still have maybe a comment or two or question. But thank you all colleagues for making the time.
May I add a very quick comment on?
Sure, Doctor. Sure, Dr. Manan.
The role of telemedicine and engaging community, the way what we have been practicing is that the program is right in the middle of the community. We have trained community workers, trained to diagnose tuberculosis, at the same time going around to villages. Now, when I am not in the village, and we have developed a system that how quickly one can interact. So from the UK, I see 3 days a week with all coming, and sometimes I talk to patients, and that's been followed up. My idea being that if in India we have a few right-minded and experienced doctors, if we could share, and that because the certain system being developed, so it's just a thought I've been thinking that now, because we are doing now in Odisha, we are in other places, so we need group of doctors and try to apply. But it's been working, particularly during COVID. I was not able to share this idea. So it is. We have tried and have some tools available.
Any other comments from the panelists, or before we close?
So I would just like to say that we would like to use some of these results that you have published and lessons learned across the 10 projects that we have been funding through this portfolio of community engagement into research and into social innovation and into ethics and into gender. It's quite a broad spectrum of projects, and we would like to put them together, some of these lessons learned, even on the methodology, even this witness seminar type of interaction to gather, grassroots information would be very helpful. And we would like to disseminate that broadly through our networks in TDR and WHO. Thank you.
Yes, Mike, that will be very helpful.
So, any closing remarks from Sunita or Anant? I can hand it the session to you as the organizers.
Well, I just want to thank everyone, panelists as well as all the participants. And I see really kind of, participants, it's late evening, long days, everybody has long days. So thank you so much. And it has been very rich conversation. And we really, I mean, it has been a lot of work to put the reports together. So thanks to the witnesses who made time, and it was a long process, almost like it took us about 8 to 9 months. And without them, we would not have been able to really put these reports together. And these are some of the acknowledgements. We are really grateful, and I'm particularly also kind of see a potential, because Michael seems to be sort of, the TDR office would like to kind of, take it forward and disseminate it widely. And it would cut across different health conditions. So it's not only the TB programs, I understand. So the lessons learned from this conversation could be applicable to other health conditions. And the other side is mental health. So it's not only infectious diseases per se. So anything that falls into the category of public health. So thank you once again, Anand. Over to you for final words.
I just also want to add my note of thanks and appreciation for everyone who joined today, all our participants, all our panelists, our moderator, Anurag, and we are very, very thankful for all of your support. Any report, any activity is only useful when it's disseminated, especially to the key constituencies. So we are hopeful that all of you will disseminate and share with your colleagues, with your communities, and we will, of course, appreciate any feedback or comments you might have. And we will also let you know once the videos from the witness seminars are released as well. So thank you again for joining, and also for your patience in staying on beyond our original time. And it was a pleasure to have you all participate. Thank you and take care.
Thank you all. Bye. Have a nice evening and good night in India.